Anemia is a prevalent condition in primary care, affecting over 3 million individuals in the United States. It is characterized by a reduction in red blood cells or hemoglobin, leading to impaired oxygen delivery to tissues. Common symptoms include fatigue, pallor, and shortness of breath. Primary care providers play a crucial role in diagnosing and managing anemia, necessitating a comprehensive understanding of its types, its causes, diagnostic approaches, and treatment options. Types of anemia. Anemia can be classified based on red blood cell size into microcytic anemia, often caused by iron deficiency, thalassemia, or chronic disease. Normocytic anemia, associated with chronic diseases, acute blood loss, or bone marrow disorders. Macrocytic anemia, typically due to vitamin B12 or folate deficiencies, liver disease, or hypothyroidism. Diagnostic approach. A systematic evaluation is essential for accurate diagnosis. 1. History and physical examination. Assess dietary habits, medication use, chronic diseases, and family history. Look for signs like pallor, jaundice, or glossitis. 2. Laboratory tests. Complete blood count. Evaluates hemoglobin, hematocrit, RBC indices, and MCV to classify anemia type. Reticulocyte count. Assesses bone marrow response. Elevated in hemolysis or blood loss. Peripheral blood smear identifies abnormal RBC morphology, aiding in diagnosis. Iron studies. Serum iron, ferritin, total iron binding capacity, and transferrin saturation help diagnose iron deficiency anemia. Vitamin B12 and folate levels. Detect deficiencies causing macrocytic anemia. 3. Additional tests. Depending on initial findings, consider renal function tests, liver function tests, thyroid function tests, or hemolysis markers. Management strategies. Treatment is guided by the underlying cause. Iron deficiency anemia. Supplement with oral or intravenous iron and address sources of blood loss. Vitamin B12 or folate deficiency. Administer appropriate vitamin supplementation. Anemia of chronic disease. Manage the primary condition. Erythropoiesis. Stimulating agents may be considered in certain cases. Hemolytic anemia. Identify and treat the underlying cause. Corticosteroids or immunosuppressants may be necessary for autoimmune etiologies. Referral considerations. Refer to a hematologist if the cause of anemia is unclear after initial evaluation. There is evidence of bone marrow failure or dysplasia. Specialized treatments such as transfusions or advanced therapies are required. For a comprehensive review, consider reading Anemia for the Primary Care Physician, which offers an in-depth discussion on anemia management in primary care settings. Additionally, the article Anemia as a Problem. GP Approach provides valuable insights into the diagnostic approach to anemia in primary care patients. By following a structured approach to diagnosis and management, primary care providers can effectively address anemia and improve patient outcomes. 1. Iron deficiency anemia. Cause: chronic blood loss, inadequate dietary intake, or malabsorption. Treatment: oral iron supplements. First line: ferrous sulfate, 325 mg PO/TID. Alternatives: ferrous gluconate or ferrous fumarate. Enhancement: take with vitamin C to increase absorption. Common side effects: GI upset, constipation, dark stools, duration. Continue 3 to 6 months after correction to replenish stores. For iron therapy: iron sucrose or ferric carboxymaltose, used for severe IDA, malabsorption. Identify and treat underlying cause. GI workup for older adults or patients with suspected chronic bleeding. 2. Vitamin B12 deficiency anemia. Cause: poor intake, pernicious anemia, gastric bypass, malabsorption. Treatment: oral B12, 1,000 to 2,000 mcg daily for mild deficiency. IM B12 injections: 1,000 mg daily for 1 week, then weekly for 1 month, then monthly. Monitor: neurological symptoms may take months to resolve. 3. Folate deficiency anemia. Cause: poor diet, alcohol use disorder, pregnancy. Certain medications. Treatment. Oral folic acid. 1 to 5 milligrams daily for 1 to 4 months. Dietary increase. Leafy greens, fortified cereals, legumes. Anemia of chronic disease. Cause. Chronic infections, autoimmune diseases, CKD, cancer. Treatment. Manage underlying disease. Optimize control of chronic conditions. Erythropoiesis-stimulating agents. Indicated in CKD, cancer, or chronic inflammatory conditions with severe anemia. Examples: apotin alpha, darbepoetin alpha. Monitor iron status. Iron supplementation may be needed to support response. 5. Hemolytic anemia. Cause autoimmune hemolysis. Hereditary conditions, infections. Treatment. Autoimmune hemolytic anemia. First line, prednisone. For warm IHA. Second line, rituximab, or splenectomy in refractory cases. Avoid cold exposure and cold IHA. G6PD deficiency. Avoid oxidant stressors, sulfa drugs, fava beans, certain antibiotics. Sickle cell disease. Hydroxyurea. Increases fetal hemoglobin, reducing sickling. Folate supplementation prevents deficiency due to high RBC turnover. Pain management, NSAIDs, opioids for sickle cell crisis. 6. Aplastic anemia cause. Bone marrow failure. Treatment. Mild cases, monitor and supportive care. Severe cases, immunosuppressive therapy or hematology referral for bone marrow transplant. 7. Anemia due to blood loss cause, trauma, GI bleeding, heavy menstruation. Treatment. Stop bleeding source. Iron replacement. Blood transfusion. If hemoglobin less than 7 grams, DL or symptomatic,